So my clinical pattern was a Colles fracture, which is defined as a fracture of the distal radius with a dorsal displacement of the distal fragment. It's often classified as a distal radius fracture. There are a ton of different types that I outlined in my clinical pattern. You would want to use the DASH, the Disabilities of the Arm, Shoulder, and Hand questionnaire for your outcome tool. For prevalence, it's the most common long bone to fracture in adulthood, and it accounts for 1/5 of all adult fractures that present to the ER, so it's pretty common. You'll likely see it in the clinic. Those older than 50 have an increased risk of having a Colles fracture due to the prevalence of osteoporosis as you age, and it occurs more than any other fracture in those 50 and older. It can also happen in the pediatric population because they have low bone mineral density. Going along with the age, women are more likely to get Colles fractures due to having an increased risk for osteoporosis. And in those older than 65, the risk of a distal radius fracture was 5 times greater in women than men. So it's really common. You'll likely see it in your adult populations, especially your female populations. For the mechanism of injury, it's most likely from trauma. In older patients, a lot of times it's from falls, like foosh injuries, so fall on an outstretched hand when the wrist is in dorsiflexion and pronation. In younger patients, it's more likely due to sports injuries or like car accidents and stuff like that. Aggravating factors include like weight-bearing activities or increased activity of the affected extremity will elicit some symptoms, and then easing factors is ice or taking NSAIDs for the pain. As for a 24-hour pattern, the wrist is likely to be stiff in the morning and kind of increased pain throughout the day with increased activity, and using that upper extremity, it can cause swelling and some pain. There are no precautions or contraindications for this exam. The patient that I'm doing for my Colles fracture is going to be like post-immobilization. So their fracture is gonna be healed, and they're just coming to therapy after they've been cleared by their physician. So there's no precautions or contraindications. It should just be the patient's pain tolerance. As for observation on the physical exam, you might see some mild edema if they just got out of their cast, and you likely will see muscle atrophy throughout the forearm and even into the hand. For active and passive movement testing, it's likely to be limited at end ranges in multiple planes just due to stiffness after being immobilized for so long, but especially in wrist flexion and extension. For resisted testing, it's likely to be weak in all planes as well, especially in grip strength. For accessory mobility, you're likely to see hypomobile palmar and dorsal glides of the radiocarpal joints, and the CMC, MCP, and carpal mobility will likely be decreased. You shouldn't really see any positive signs if you do a neuroscreen unless there was nerve involvement when they had that injury. And then you don't have a need to do special tests. And for palpation, it's likely to be tender all along the distal radius. For differential diagnosis, there's a ton of different ones just because so many injuries can happen, different types of injuries can happen at the distal radius. There's a Smith's fracture, which is an opposite Colles fracture because it happens on the volar aspect of the wrist, and it occurs when the arm is in supination rather than pronation. There's also a ton of different fractures, other distal radius fractures or ulnar fractures or radial head dislocations that can happen, or ligamentous injuries as well that can get confused for a Colles fracture. For diagnostic imaging, an x-ray is usually the first step. You would want to see PA and lateral views to get an idea on the fracture and if there was that dorsal displacement that's defined by a Colles fracture. Physicians will do a CT scan if they need for surgical planning or to see if it's an intra-articular fracture. And then MRIs are really only done by physicians if they suspect like a ligamentous or soft tissue injury as well in the area. So your patients will really only have that if there's that. Signs and symptoms indicating a referral to a physician would be absent pulses throughout the extremity, or if they have any diminished sensation through either the ulnar, median, or radial nerve pattern, just to make sure that nothing else is going on. As for surgical indicators, there's really nothing with a Colles fracture because they already had that immobilization period and they've already been seen by a physician. But if their fracture wasn't healed right, if they re-injured, then that would be another surgical indicator. But other than that, that's it.